Good afternoon. Thank you for inviting me to speak, and thank you for taking on such an awesome responsibility. My name is Charmian Proskauer. I'm president of the Massachusetts CFIDS ME and FM Association. I'm also a member of the Let's Get It Right team. My written comments are more complete than these brief remarks and also include references to back up my statements. I'm here to speak on behalf of children and adolescents with ME/CFS. Children and adolescents are an important group to consider separately, not merely as a subgroup of the adult illness. For the last 2 years, our association has been working to educate school nurses about ME/CFS in children and adolescents. School nurses can serve as gatekeepers to help identify ill children who may have ME/CFS and give information and support to their families and to the school. There are several conditions that would alert a school nurse or an informed pediatrician to the possibility of an ME/CFS diagnosis. The clinical presentation, while variable, fits into patterns that are described by the existing case definition for pediatric ME/CFS. The illness often follows mononucleosis. 13% of mono cases develop into ME/CFS. As an adult ME/CFS, symptoms can wax and wane. A child who arrives at school and seems okay may need to go home by lunchtime. A pattern of variable symptoms over time may be an indication of ME/CFS. ME/CFS is the most frequent cause of prolonged absence from school, and it is this prolonged absence that often leads school officials down the wrong path of falsely labeling ill children with school phobia or taking the parents to court for medical child abuse. Children with ME/CFS want to go to school and will tell you that if you ask them. A separate clinical definition for pediatric ME/CFS has been developed and should be added to the list of clinical definitions that you consider in your study. The adult definition is not appropriate for children and youth, as the initial presentation of symptoms may be quite different from that of adults. Also, it may not be appropriate to ask an ill child to wait until the symptoms have persisted for 6 months, which is most of a school year, before receiving a diagnosis which will allow helpful management and treatments to be put into place. While the onset, symptoms, and course of the illness in youth can be quite different from that in adults, as in adults, the symptoms vary in nature and intensity on any given day. This variability can cause providers and others uninformed about the illness to believe that the symptoms are psychological. Also, as in adults, the illness is usually prolonged, lasting from several years to 10 years or more. When a child changes schools, often the process of educating school officials has to start all over again. The range of issues needing to be dealt with in children is also different. Important aspects for a child include their educational needs and social development, as well as their physical health. Addressing these issues involves the school, the family, and the community, as well as the providers of health care. Families with a chronically ill child already face many challenges. Caring for an ill child who does not have a recognized diagnosis, or with a diagnosis that family, friends, and school officials do not understand, is especially difficult. Without a diagnosis, the more severely ill a child is, the more likely the family will be under pressure from the school and the threat of legal action against them. Pediatricians, at least in our state, have little knowledge of ME/CFS. When a school nurse recognizes a child with symptoms suggestive of ME/CFS, it's usually very difficult or even impossible to find a pediatrician who can make the diagnosis, which would allow the child to receive educational accommodations and begin appropriate treatment. Lacking a correct diagnosis, I just want to emphasize this point, there is a significant risk, especially with a severely ill child, that an incorrect diagnosis of medical child abuse or Munchausen syndrome by proxy may be given, and the situation may escalate to the point where the child could be removed from the home or legally required to undergo an inappropriate treatment. On the positive side, outcomes for youth If good information, treatments, and social and educational support are provided promptly, seem to be better than that for adults. However, it should be noted these studies on outcomes do not include the most severely ill children, so we don't know the outcome for them. In summary, we urge this committee to give pediatric ME/CFS sufficient attention during your review. You should add the existing clinical definition for pediatric ME/CFS to your scope of study. Your plan to educate physicians should explicitly address pediatricians and school nurses, as well as the providers of adult care. Pediatricians need to be confident in diagnosing this illness as a physical and not a psychological one. Please do not defer this. Great harm is being every day done to children and families due to lack of knowledge. I'm out of time, so I'm just going to put up my last slide, which reiterates the points a few other people have made about care to be taken during your review of the literature. But I would also like to just mention the last point, because some journals, some mainstream journals, have refused to even consider publishing articles on ME/CFS. So sometimes ME/CFS researchers have had to look for non-traditional avenues to publish their work. So I would implore you not to overlook these research contributions just because they may be published in journals that you do not usually read. Thank you very much.
Thank you so much for your comments. They were really very helpful. And Ted, you look like you have a question. Oh, Nancy first and then Ted.
Thank you. That was very, very helpful. And as someone who's dealt with a number of these Munchausen by proxy cases in my clinical practice, I can't underscore enough how devastating it is to the family to see their child literally seized from them. And I had one child who was forced into a foster care situation where they did morning calisthenics before he was shipped off to school with devastating consequences. So it's an exceedingly important area, and I know that the committee is certainly intent to consider these things. I will say that since the pediatric case definition came out, I haven't seen a lot of other studies to follow. And again, if the public has additional information, even if it's alternative types of information on how the pediatric case definition has been applied, I think it would be very helpful to us.
Yes, thank you for your presentation. I'm intrigued by the idea of trying to diagnose children earlier. That is good. But whenever you start diagnosing earlier, you'll have some false diagnoses. And because obviously if you take it to the extreme and have it only be 1 day instead of 6 months, then you're going to have problems. If you wait 6 months, you have problems. So the question is if you have any data or know of any data on length of time of symptoms and how well that's correlated with a final true diagnosis.
I believe that the existing pediatric definition, which was published by Lenny Jason and colleagues, suggests a 3-month waiting period. And I don't know how that correlates with long-term illness. Is that what your question was?
That's related, yes.
Yeah.
Thank you.
I don't know that answer.
Thank you so much. I really appreciate your coming here and sharing your observations with us. Our next speaker is Mary Schweitzer from Wisconsin ME/CFS Association.